Hello and welcome to Kaweah Health's Community Engagement Webinar. Today is Monday, November 21st, and my name is Deborah Volleson, and I'm the Director of Community Engagement. Normally we say it's Thursday because we normally do these on Thursdays, but hopefully on Thursday this week you will be sitting down and enjoying Thanksgiving with your family. Like usual, I am joined by Gary Herbst, Kaweah Health CEO, and we are here to answer the questions that have been submitted. And like every webinar, if a question comes to you during the live broadcast, go ahead and chat it to us and we will add it to our conversation. Hi, Gary.
Hey, Deborah.
How are you?
How are you? Good.
Good?
Yeah.
All right, so
Yeah.
COVID it was down, it's kind of going up, and so we're still pretty low,
Yeah,
but we're very busy.
It definitely has not gone away. I can tell you that for certain. And now we have other viruses that we're dealing with as well, like the flu and RSV and who knows what's else out there as well. So
what else is looming around the next corner?
Yeah, I know. I was reading over the weekend the new variants that are emerging from COVID that we're now past BA.4 and BA.5, and I think we're into the Qs now, and so I can't even remember what they were. So, but I thought I would. It's been a while since I've given kind of a COVID update,
okay.
And then just talking about how busy we still are as a hospital. So, so today, this morning, we currently have 22 COVID positive patients, all adults that are in the acute medical center and that have actually been admitted. It was just a few weeks ago, I think we were down to 6 or 7. So it looked like it really was fading away and might even disappear. But then as the weeks went by, it's starting to click up. Today at 22, that's more than I've seen probably in a couple months now. We also have 2 COVID positive patients that are holding in the emergency department waiting to be admitted. So the total number is actually 24. Fortunately, the strains that we are seeing and testing for are definitely much less severe than Delta or even Omicron or the original version because none of those 24 patients are in critical care. So none are in the ICU or the ICCU, and none of them on ventilators. So that's still a positive thing. It's primarily, again, older people that are ending up in the hospital. We're no longer tracking if they're vaccinated or boosted or anything like that. And then they're staying on average, say 3 to 5 days. Definitely those that are staying longer, but most all of them are recovering. And in fact, it's still about 50-50 in terms of those that are in the hospital because of COVID or happen to be in the hospital. Another 50% are in the hospital for a different reason, but they still tested positive for COVID. As you might expect, as we enter this winter season, it feels like fall just skipped us all together, and amazing how low the low temperatures have gotten. But we are at about 93% occupancy in the acute medical center. That's the adult occupancy. That also includes about 20 patients that are holding in the emergency department, that they've actually been admitted, but we don't have a bed for them. And when I say that, we do have beds, but they may not be the appropriate level of care for that patient. Because as I was looking at the census this morning, we have 22 of our 41 ICU beds are open. 15 of our 54 ICCU beds are open, but only 8 of our 237 medical surgical beds are open. And so oftentimes those patients that are down in the ED, they don't need that critical care bed. They really need a medical surgical bed, and that's where we were the most impacted. We also have 7 children that are patients right now. So we have a 12-bed pediatric unit, and we've been running anywhere from 6 to 12 patients pretty consistently since the onset of RSV. And it definitely has been an unusual year for RSV. It's hit both children and adults. tends to be infants and young children, but also older adults as well. I know that we've had to transfer a lot of kids up to Valley Children's, but we're also transferring them to Children's Hospital in LA and the Bay Area because we haven't been able to care for all of them in our kind of small unit. So we currently have 23 employees and 1 provider that are out on a COVID leave of absence. So again, despite all of the measures that we take to protect ourselves from contracting COVID, we definitely are not immune from it, particularly when we're out of the hospital. We're probably least likely to get it in the hospital because we're all donned up in PPE, but like everybody else, we go home and probably don't quite have our guard up the way we used to these days. Thought I'd give you a little update on flu and RSV. So we started our surveillance measuring on October 30th, so just about a month ago. So between October 30th and November 12th, so we're really looking at just a couple weeks there, we've already had 591 confirmed cases of the flu, and we've had to admit 20 of those patients with the flu. And we've had 161 cases of RSV, and we've admitted 11 of them. 92% of the flu cases that we have seen are influenza A, so that's a good thing. We're not seeing, these kind of off-the-wall variants. It's the kind of the traditional flu, so definitely this is still vaccination time, so absolutely you can still get vaccinated. And again, like COVID, getting vaccinated will not prevent you from getting the flu, but it should prevent you from getting really, really sick, being hospitalized, or even dying of the flu. And definitely the flu shows no discretion. We, of those patients that we've admitted, our youngest was 2 months old and our oldest was 94. So it doesn't care about your age, it doesn't care about your gender or your ethnicity. It really targets anybody it can. So definitely encourage all of you to consider getting a flu vaccine.
Do you have like comparisons, like that 591 flu cases? Do we know how that compares?
Yeah, shoot, I didn't bring it with me. I think we'll do a huddle here in December, and I'll do that comparison.
And RSV, I mean, it's not just us. Like you said, it's statewide. I was on a regional call the other day. Pediatric wards are full, children's hospitals are full. And so Dr. Tu, in our emergency advisory council meeting, we were asking him how they can prevent children from getting RSV. And he says it's actually passed down from adults to children. So he said, just be really careful when you're around young children, especially new babies. So, because we're not masking anymore and everybody's susceptible.
Well, we talked about too that, kids have been out of school for a couple years. And so most of the time children develop their immunity from being exposed at school. That's why oftentimes in the winter you'll see some of the biggest flu outbreaks will occur in elementary schools and high schools too. But when kids are around each other, they're in classrooms, and so that's generally good for them. But we've been so isolated for so long, I think our immune systems are a little bit weakened.
Yeah. Okay, so let's move over into the financials. You did kind of a community roadshow with our advisory committees, although roadshow makes it sound a little more fun than what it was, but you went around to several committees and talked about the financials from July through September. And so the question that I get asked frequently now that we are in the third week of November is, how were the October financials?
Right. Yeah, so those groups, I think, in fact, the community engagement group with our ambassadors was one of the first groups I'd met with, so I didn't have October results. But earlier this week, or no, it can't be earlier today's Monday, right? Okay, so late last week, I met with the Patient and Family Advisory Council, and I did have October's results at that time. And Gosh, how do you put it? I'll say they were better than July, August, and September, but still were not good. I would never celebrate, having an operating loss, but in this case, it being the smallest of the 4 months that have passed so far this fiscal year, it was a bit encouraging. You may recall that I shared that in the month of July we lost $8 million, and that's the amount by which our expenses exceeded all of our revenues. We lost another $8 million in the month of August, and then we lost $12 million in the month of September, when I think we actually had peaked on our use of contracted labor at a time that we also experienced a very soft demand from patients, both on the inpatient and outpatient side. So just in those 3 months, we'd accumulated about what's the math there, $29 million loss roughly. For the month of October, we had a loss of $5.8 million. Definitely nothing to celebrate, but some of the things that we've put in place, renegotiating supply contracts, renegotiating some of those contract traveler rates. Unfortunately, we've already laid off more than 100 employees. We've closed more than 100 open positions. So we are seeing some of the positive results of taking very difficult, action to trim our sales. So good to see it moving in that direction. It was really, October was an interesting month. We spent $77.5 million to operate the hospital in the month of October. So obviously it's a very large healthcare system, very complex, and healthcare is very, very expensive right now. But that was only about $692,000 more than budget. So it's really been over the course of the pandemic and the first 3 months of this year that our expenses were way over budget. But in this case, they're only 0.9%. So that was very encouraging. But what we weren't expecting is that we came in way under budget in revenue. And again, I mentioned that volumes have been a bit soft on both the inpatient and outpatient side. We still haven't seen our surgical and procedural volume bounce back to pre-pandemic levels. And everything I read across the country is that hospitals and medical groups are experiencing soft demand. And I can only speculate, but I do think that folks are still fearful of going to the hospital, going to the physicians. We know that sick people go to doctors and go to hospitals. And so do you want to be there in the waiting room, at your physician's office or the hospital if you don't have to be? So I think folks are putting off elective procedures, waiting on that knee surgery or that shoulder surgery. So that definitely is having a negative impact. So through the first 4 months of the fiscal year now, Kaweah Health's operating margin stands at a negative $34.4 million. Our total operating revenue of $280 million, that's how much we've generated over those first 4 months. That is $20 million below budget. And we've already spent, just in 4 months, $26 million on contract labor, which exceeds budget by almost $17 million. I was talking to Dr. Glade Roper this morning, who's one of our radiologists. He was asking me if the hospitals and Kaweah in particular had ever experienced tough times before. And having been here 30 years now, I've lived through the good times and the bad, which mostly have been good, but there have been times that we have struggled. There have been nursing shortages in the past, and I was sharing with him that I still remember the year that we spent $8 million on contract labor. It was a record. Never had we spent that much money. We've used contract labor periodically, when we've had positions that we might have difficulty filling. But usually it might be $1 million, $2 million, but to have spent $26 million just in 4 months of this year is, again, just unprecedented. And that's really that's the single most important variable or factor that's causing the financial hardship across the hospital industry. It's literally impacting every hospital in every state across the nation. So we're going to have to continue on our journey to financial recovery. We actually, the executive team and the board, have created a plan that will trim our sales either through revenue enhancement or cutting costs. The last thing we want to do is lay off employees, so we'll continue to tackle those non-labor opportunities, supply contracts, vendor contracts, negotiating with commercial health plans in terms of what they pay us. I've shared with you that our executives and our directors all took pay cuts and will not be receiving a pay increase that they normally would get on January 1st. So yeah, I mean, October not great, but definitely moving in a better direction.
But we knew, I mean, and you knew that it would take a while, especially with contract labor being on, 4 to 6 week contracts.
Yes.
So doing away with those, you would still have to, go through the cycle of those. So are you hopeful?
Yeah,
Come on,
no,
you're
definitely.
hopeful, Gary.
Yes, I am hopeful, although I'm being tested. But I'm still a hopeful optimist. And I have tremendous confidence in this organization. And as difficult as it is for us, because we are a very compassionate, caring organization, and one of our pillars is to create and maintain an ideal work environment, for our employees. And so it's tough when you're having to do the kinds of things that we're having to do. But so yeah, just a few weeks ago, we were at 240 traveler RNs, and I think as of yesterday, we're down to about 165. So that number is definitely coming down, and just going from 240 to 165 will save us tens of millions of dollars in expense. At the same time, we were also paying anywhere from $180 to $220 an hour for those contract nurses, and you juxtapose that with the $50 to $55 which is a very good salary, very competitive, but that's what an employed nurse generally makes straight time per hour plus full benefits. So when you're normally, in a non-pandemic period, you're paying $50 to $55, and now you're paying $180 to $220. That's also what is really contributing to the challenge. So we've now been able to negotiate, because the market for contract labor has been softening across the nation. Nurses are returning back to their hospitals, and so rates have started to come down. We've managed to push some of those 180 hourly rates all the way down to 130. We're continuing. Our goal is to get it down to 110, which is still twice as much as what we'd pay an employed nurse, but still a far cry from that 180 to 220. So ideally, we get that rate down to 110. We continue to hire nurses so that we wean ourselves off of those contract staff, and that should have a very, very positive impact on our recovery.
Okay. So you mentioned trimming the sales. What are some areas that you have shut down or eliminated here at the hospital?
Yeah, sadly, the first one we did was our 22-bed skilled nursing unit located over on our Court Street facility. That's a 54-bed long-term care facility that all 54 of those beds are skilled nursing beds, but 32 of them are used to take care of what we call subacute patients. So those are patients that have suffered, a major, oftentimes brain injury, a stroke, a traumatic accident. Many times they're dependent on a ventilator to breathe, and they stay for very long periods of times, often in excess of a year, 2 years, 3 years. The skilled nursing side, the 22 beds, has generally been for shorter stay patients, and so these are generally patients that are discharged from our acute medical center that aren't quite ready to go home and they could benefit from some additional care. They don't need that really intense, acute care in the medical center, but again, not ready for home, where they could be taken by home health or family. And so they might spend a couple weeks in the skilled nursing facility receiving rehabilitation and other things that get them ready to be independent at home. So we've now discharged all but 2 of those patients. So they've all been discharged home now. But 2 of the patients actually are very long-time residents. In fact, one has been living there for 16 years. Because after so many months, that actually becomes their place of residence if that's what they choose. And so we're working with those patients and their families to place them in another skilled nursing facility, ideally one that's local here in town. So, and most all the staff that were working there will find jobs or already have found other jobs in the hospital. Certainly the RNs, the LVNs, the MAs, we definitely have a place for them to come. But it is still really, really hard for them because this is where their heart is. These are the patients that they really enjoy taking care of, great meaning in their lives. And I know the patients view them as their family, and so it doesn't make it any less painful to have to do that. We also then recently announced the closure of our neurosurgery outpatient clinic located in the 202 West Willow building, the 5-story right next to the helipad. So we continue to provide 24/7 neurosurgery services for traumas, the emergency department, acute inpatients that might need a surgical procedure. So that will continue with Dr. Chen and Dr. Liu and Dr. O and the USC group, but we'll no longer have that outpatient clinic, which interestingly, very few of the visits to that clinic ever resulted in surgery. The physicians found themselves often taking care of patients with chronic back pain. The majority, unfortunately, of the patients were Medi-Cal, and actually 25% of them did not even live in our community. They were coming from Fresno and Bakersfield and Kings County because they heard that we had a neurosurgery clinic that was open to all, irrespective of your ability to pay or not, which is why, unfortunately, that the neurosurgery clinic was losing over $1 million a year because, unfortunately, we have not seen an increase in Medi-Cal outpatient reimbursement rates for 30 years. That's the last time we got an increase from the state, 30 years ago, which is why we're lobbying for an increase in reimbursement rate. So we had to close that clinic, or it hasn't closed yet. It'll be closing in December. Same with the skilled nursing facility. It's not closed yet. But obviously, having discharged all the patients, we're not admitting new patients to it. And then most recently, we closed our outpatient diabetes clinic as well. And so again, finding homes for those staff, and it looks like most, if not all of them, will find another position within the district or within Kaweah Health. But there's no doubt about it, it will impact patient care. It will impact their access to patient care. And oftentimes, the patients that we are taking care of are some of the most impoverished. And we have the highest Medi-Cal enrollment rate of any county in the state of California. And when we've been profitable in the past, we've been able to provide any and all services to that Medi-Cal population. We provide a lot of elective surgery, both inpatient and outpatient surgery, to the Medi-Cal population at significant loss. But when you're profitable, you can have those services that don't have to make money. They're really all about taking care of your community and serving your mission. But when you're facing the financial challenges we haven't seen an increase in our inpatient Medi-Cal rates since 2009. So 13 years ago, and then 30 years on the outpatient side, and yet we continue to provide that that care. So unfortunately, we're having to look very carefully. We've met with one of the big Medi-Cal managed care plans, HealthNet, and we went over every single service and showed them the losses that we incur year in and year out while they're making record profits, HealthNet and Anthem Blue Cross off Medi-Cal. And so we've got to see some change there, or we are going to stop providing those surgeries and procedures.
So the diabetes clinic, will patients just have to start going back to their primary care physicians? My mother comes to the diabetes clinic
Yes.
with Humana, and so...
Yes, I don't know of any other institution-sponsored diabetes clinic here in town. So yes, and obviously, Tulare County has one of the highest prevalencies of diabetes in the state, if not the country. We have some great endocrinologists that work in this community. So yeah, and a lot of community physicians are very experienced and knowledgeable in treating diabetes. So yes, that will be the thing they'll have to do. And our clinics, our rural health clinics, scattered throughout Tulare County, they also managed diabetes. So there will be options for them, but I know a lot of our patients really loved coming to our diabetes clinic. We have a registered dietitian right there, Jean, that has been providing that care for years. So it is very sad to see that it's shutting down, but it, like these other programs, was losing $200,000 to $300,000 a year, and we just couldn't afford to subsidize it anymore.
Okay, so I'm going to jump back up to the financials where you talked about contract labor. So a chat just came in. So would significantly raising the wages of your regular nurses impact the need for travel nurses?
Yeah, I think the short answer is yes. In fact, we're looking at that as an option. Right now, Diane Cox, our Chief Human Resources Officer, and Melinda Tupper, our Chief Financial Officer, are exploring this program that they're calling 7 for 7. So an RN, a bedside RN, normally works 3 12-hour shifts in a week or 6 12-hour shifts in a 2-week pay period. And we are exploring the affordability of giving them a $7 an hour pay increase if they'll work a 7th shift in a pay period. So work 3 12-hour shifts in 1 week, and then four 12-hour shifts in the subsequent week for 7 shifts. And if they will do that, we will pay all those shifts at a higher hourly wage, a $7 higher. Now, obviously, that is still going to cost a lot of money because we're not getting any increases in payer reimbursement. But the thought is that it will still be less expensive than what we're paying for a contracted traveler nurse. Plus, in this case, 100% of that salary goes to our nurse. So we'd much rather pay our own nurses, our employed nurses who live in our community and spend in our community, and than to pay, $100 and something to a contract agency that only a certain amount goes to the nurse and the rest is left for profit. So, but, I would love to raise that rate, but it's a matter of, but can we afford it? Unfortunately, we probably can't afford not to, because it's still very, very competitive. And when every hospital, up and down the state is experiencing the same thing, we literally have ignited a wage war several years ago, where we just keep trying to outbid each other to, get nurses, and offering huge sign-on bonuses and relocation bonuses, and just keep raising the rate while at the same time not receiving any additional reimbursement. So we're all deficit spending. Hospitals, we're just spending our cash reserves to support the operation. So you got to find that balance, but I would definitely love to shift away from contract staff.
So a couple of weeks ago, you wrote a letter which was published in the Times Delta, and it's gotten a lot of attention. And so we've been asked at the community meeting. So first of all, I want you to just kind of summarize your letter and why you wrote it. And then we've been asked at every community group that you went to, what can I do to help? What can we do to help? And so let's talk about that a little bit. So summarize your letter and give us, why did you decide to do that?
Yeah, thank you. Well, throughout this pandemic, which started in March of 2020, hospitals have stood really tall, amazingly, selfless, dedicated. It's not the hospital, it's not the organization, it's the people in the organizations that at great personal risk, we're so courageous in taking care of our communities. And it caused hospitals to really suffer financially. We lost $35 million just in the three and a half months of 2020. So when it arrived here on March 13th of 2020, and by June 30th of 2020, we'd lost $35 million. And pretty much repeated that every year over the course of the pandemic. Fortunately, the federal government, through the CARES Act and the American Rescue Plan Act, set aside $100 billion for U.S. hospitals to help them. It was far, far less than the actual losses that U.S. hospitals experienced. In fact, over the course of the pandemic through October 31st, we've lost a cumulative $130 million, and we received $61 million in federal COVID relief funding. So less than half of that was recovered. So the balance all came out of our cash reserves and put us kind of in this financial strait that we're in right now. But throughout this whole pandemic, the state of California, who also received $100 billion in COVID relief funds from the federal government, has not supported its hospitals at all. We did, and I appreciate this, we were one of the areas that was really surging at one time. And so I think it was from September of 21 to like March of 22, the state provided us with about 50 contract staff, most of them nurses, but also respiratory therapists, and at their expense. So it was several $million, but nowhere near, what we had lost. And so when the governor was touting the record $100 billion budget surplus that the state generated in the year just ended June 30, 22, and I'm reading, these reports about California hospitals. Hazel Hawkins Hospital in Hollister just filed bankruptcy. They're a small district hospital, but really important to their community. And so you got all these California hospitals, including Kaweah, that are really suffering substantially in an unprecedented fashion. And the governor and the legislature's figuring out, how do we spend this $100 billion surplus we have? And so I guess I just gotten fed up, and I said, we have to speak up. We have to cry out. Not that we hadn't been doing that. The California Hospital Association, the District Hospital Leadership Forum, we've been pleading with the governor and the legislature since the beginning of the pandemic for financial support, but it's fallen on deaf ears every single year. And so I wrote my letter in hopes that, drawing attention to a real, not some lobbyist organization like CHA, but this is what's happening in, one community in your state. And I do appreciate it's got a lot of attention. It got picked up by some national media outlets, which now has spurred on tons of emails and community interest. And I know the Visalia City Council and the Board of Supervisors are writing a letter to the governor and the legislature. So yes, I would love the support of the community, and what we're hoping to do this week, partnering with the public relations firm that we've worked with pretty extensively in the past, does phenomenal work. That he has some pretty simple technology that will allow us to put template letters on the Kaweah Health website, and some technology behind it that'll let the community member just maybe put in their name and the city and they live, and then it will populate that letter with your plead for support of your local hospital, and we're asking for that one-time financial support, but also asking for increases, long-awaited increases in Medi-Cal reimbursement rates. And so with just the push of a button, you'll be able to send that letter to the governor and our local legislators, and it'll automatically put in their email addresses for you and everything, so you won't have to lick a stamp. You'll just, boom, just be able to push that button, and your voice will be heard.
I love the questions that you have gotten. Has the governor called you?
He has not.
Expecting a call from
Well,
the
you
governor?
know, I thought maybe at least from his chief of staff, something like that.
Somebody.
But yeah, I did a almost hour-long interview with NPR radio last week, and they called the governor's office and asked if they'd received my letter or read it, and they said no, that they hadn't received it and they hadn't read it, even though I sent it electronically, by email, and by mail. So maybe they just don't want to talk about it.
Or maybe they have no more money to give, right?
Well, there's truth to that, at least according to the newspaper. So this weekend, which is maybe why I'm not going to get any response, is the state's now reporting that I think they've incurred about a $30 million budget shortfall, or billion. It's in the billions. In the current fiscal year that started July 1, their tax revenues that have been coming in are far less than what they anticipated, and they're now staring down a pretty sizable budget deficit. So I think the response I'm probably going to get is, I'm sorry, Gary, we already spent the $100 billion in budget surplus from last year, and now we don't have any surplus. So.
Yeah. Okay, so I'm going to jump to a question about the fact that we're a district hospital. And so the question is, why don't we leave the district hospital model and move towards more of a community hospital? You know, what are the pros versus the cons of being a district hospital, and can we change that model?
Yeah, it's a good question. In fact, it's the one that Dr. Roper asked again this morning. And I do get asked it fairly frequently. So being a district hospital is really how we're organized as a corporation or organization. So when you look at St. Agnes, Community Regional Medical Center, Valley Children's Hospital, Adventist Health, and if you think of them as community hospitals, they are nonprofit, private hospitals. They are organized as 501c3 tax-exempt organizations. They appoint their board. They're not elected. They cannot issue general obligation bonds that are supported by taxpayers, but they can issue tax-exempt revenue bonds. They can invest in the stock market as well as the bond market. They do participate in certain state supplemental Medi-Cal programs like the quality assurance fee. Then there is us. So we are actually owned by the community. We are more of a community hospital than any of those hospitals. We are owned by the community. And you elect the board, the people to represent you on the board. So they're not appointed, you actually elect them. And they serve the 5 different zones that are within the district. As a public hospital, all of our meetings are open to the public. So all of our board meetings and our committee meetings, where if you're one of these other hospitals, your board meetings are closed to the public. So you're not allowed to attend the St. Agnes board meeting But as a district hospital, we are a public hospital. So that's really the big difference is we are a public hospital and they are a private hospital. But we're both tax exempt, we're both nonprofit. The only public hospitals that exist in California are the 33 district hospitals, county hospitals, although there's fewer and fewer of them. Merced Community Medical Center used to be a Merced County owned and operated hospital. Kern Medical Center in Bakersfield used to be a county hospital, but they are no longer county hospitals, so they're no longer public hospitals. And then all the University of California hospitals are public hospitals. So county, district, and the UC hospitals are public hospitals. So one of the benefits of being a district hospital, besides the transparency and the openness, is that we participate in Medi-Cal funds that the private hospitals do not. So they're called intergovernmental transfers. They're only available to public hospitals, but there's things that public hospitals have to do to earn those funds. We also do participate in the quality assurance fee like the nonprofit private hospitals, and we can issue general obligation bonds. So like water districts and school districts, healthcare districts can issue general obligation bonds, but only if they're approved by the voters. And for a district hospital to issue a GO bond, it has to have at least 2/3 affirmative vote. District hospitals cannot invest in the stock market, so we can only invest in the bond market, which is really hurting us right now because as interest rates are soaring again, as the feds keep raising interest rates, the value of our fixed income investment portfolio declines. And so, but that's also hitting the private hospitals too, but they're also getting pummeled in the stock market as well. So another benefit of being a district hospital is you do get a little bit of taxpayer support for operations. So that 1% top line of your property tax bill, every special district in the county gets a little sliver of it. And so our sliver is $1 million. It's a lot of money, but when you spend $900 million a year to operate the hospital, it funds about a half a day of expenses. The rest of the time, we are exactly like these private hospitals in that all of our revenue comes from Medicare, Medi-Cal, private insurance. So if we were to go from being a public hospital to a private 501c3, I don't really see any real change because all the hospitals that I just mentioned are hurting financially as well. Common Spirit, one of the largest nonprofit private health systems in the United States, just posted a $1.3 billion loss for the year. Providence Hospital, a private 501c3 51 hospital health system located up in Renton, Washington, just posted a loss of $1.2 billion and is laying off thousands of employees. So being public or being private, you're not insulated or protected in any way from the savages, the financial savages that that we're all experiencing right now. So it would take a vote of the people that live in the healthcare district to disband the district and to convert to a 501c3. There actually, I think, have been 2 or 3 district hospitals that have done that over the last several years, maybe over the last decade. Tulare Healthcare District, still exists as a healthcare district, still owns all its buildings and everything, but they now lease them all to Adventist Health, the 501c3 private nonprofit hospital. So I think what a lot of hospitals like us are considering right now, we're not at this current time, but is there strength in numbers? Do we join a larger organization that maybe has deeper pockets, although those deep pockets are getting holes in them, like a big health system like Common Spirit, not protected from the financial challenges. But when you're a big system, you enjoy the economies of scale. You can centralize, administrative functions like billing and coding and things like that. So maybe you're able to do it less expensively. So, but that's not in our cards right now. And we think that, we've got the right plan to get back on our feet. We have no, people talk about, was Kaweah filing bankruptcy? Is my pension safe? No, we are not filing bankruptcy. That is the furthest thing from our minds or plans. And your pension is safe. So we'll get out of this. There's no doubt about it. I have full confidence and optimism that we will. It's just the unprecedented nature of what we're experiencing. Obviously, when's the last time we came off a 2.5-year worldwide pandemic? I don't think many hospitals and the people that are leading them right now have ever faced something like this.
Okay, thank you, Gary. So why is Kaweah going to the expense and work of doing their own nursing school when there are several nursing programs in our local community that could just be expanded?
Well, we have been doing that. So we work closely with San Joaquin Valley College. We work closely with College of the Sequoias, and they've been phenomenal partners. We were working with Jonna Schengel, who oversees the COS program, and congratulations to Jonna and her team. They just got approval last week from the California Nursing Boards, BRN, the Board of Registered Nurses, thank you. Seems so simple, huh? The Board of Registered Nurses just approved COS to permanently increase its nursing program by 20 slots. And these slots, 13 of them have been earmarked for Kaweah, and they are specifically for part-time students. So students that have to work, that they can't be a full-time student because they have a family to support, they need to work, but they want to get their nursing degree. So it's designed for nights and weekends and specifically for those part-time employees. San Joaquin Valley College, also, we just had a great meeting with them just a couple months ago about expanding their program. Unitech is something that we've been working on for some time, and I'm delighted to report that the BRN also approved the Unitech Kaweah nursing program, as well as the Unitech Sierra View Hospital nursing program in Porterville. And so we are both partnering with Unitech. Kaweah will be given 25 slots twice a year, so the fall class and the spring class, 25 going into each of them. If you already have all your prerequisites done, it's a 2-year program to get your bachelor's degree in nursing. It's year-round, again, nights and weekends. It's designed for employed students. And then if you don't have any of your prerequisites, you're right out of high school or, making that decision, hey, I think I want to become a nurse, then it's a 3-year program. But Kaweah is helping support the students, so they'll apply for financial aid just like they would to any college or university, but we are going to provide financial support as well. And the reason that we are doing this, so there was an article in a publication called Health Affairs back in October, on October 26th it was published. And the author wrote, "The national nursing shortage is a continuing problem as a substantial segment of the labor force is approaching retirement, and the shortage of new nurses is projected to reach 450,000 by 2025. I mean, that's a little over a year from now. And nationwide, to have a nursing shortage that severe, that deep, and it will hit hard here as well. In fact, the more non-urban, more rural, the San Joaquin Valley, we don't have the same resource pool that you see in the metropolitan areas, the Bay Area, LA. And so we have to make this investment, for the midterm and the long term. Certainly what we talked about earlier, we have this immediate, emergent need to bring nurses on and to swap out traveler nurses for employed nurses. But we need to be thinking ahead. And so having this program like Unitech is really, really important to growing our own nurses. There will be a contractual obligation that they have once they become a nurse, that they will have to work for Kaweah for a number of years. And hopefully they love the place, they love our community, they want to stay and make this their permanent home and where they practice. So we also work with Pacific University. We work very closely with Fresno State. Diane Cox have met with the dean of nursing there on a number of occasions. So we're really trying to tap into any and all resources that we can. And we know that the traditional schools like COS and Fresno State, Fresno Pacific, they also have to apply for an expansion, and they're just given so many slots, and their ability to attract needed faculty to support those. So Unitech is very focused on healthcare careers, not just RNs, but this is kind of we're using the traditional models of on-site learning at COS and Fresno Pacific, but then also this kind of virtual approach, because the Unitech is largely taught through the didactics through virtual learning, and then the on-site internships, the clinical rotations through our simulation lab, or right here at Kaweah, where you don't have to go someplace for those clinical rotations.
All right, thank you, Gary. So do other hospitals in the area treat the same percentage of Medi-Cal patients, and do they get the same reimbursement rates as Kaweah?
So there are 58 counties in the state of California. Again, Kaweah has the highest residents or enrollment of any county. 60% of our residents are at, below, or near the federal poverty level, and so they qualify for Medi-Cal. I would say that we probably also have, in terms of the percentage of the patients that we take care of, which is close to 40%, if not slightly higher than that. I know for a fact that is significantly higher than many, many hospitals across the state take care of. There's no doubt about it that Community Regional Medical Center, Valley Children's, they probably see many, many Medi-Cal patients as well. I don't think as high as that. Children's might, being the only children's hospital in the Valley, I suspect that a high percentage, I think I'd heard at one time that more than 60% of their patients were Medi-Cal. In terms of the payment rate, so Community Regional Medical Center, Adventist Health, pretty much, again, whether you're a private, not-for-profit hospital or a public hospital, we all get paid the same rate from the Medi-Cal program. Now, that said, in Tulare County, Medi-Cal moved away from its historical state-paid fee-for-service model back, many, many years ago. And so each county kind of has a different Medi-Cal managed care model. In Tulare County, we have what's called the two-plan model, where we have Anthem Blue Cross as kind of the local healthcare initiative. They contract with the county to be that local initiative. And then we have Health Net is the mainstream plan. So there are about 250,000 Medi-Cal beneficiaries in Tulare County, and most all of them are enrolled in one of those two health plans. We negotiate our Medi-Cal rates with those two health plans, but there's not a whole lot of room for negotiation. Oftentimes the outpatient, you're just paid the state's fee schedule, which is that fee schedule that hasn't been increased in 30 years. Or you get paid what the state, when they do pay on a fee-for-service basis, is what they pay for an inpatient case. So the state pays the health plans a per member per month premium, like you typically see out as an employer, and then they pay that to the health plan, and then the health plan goes out and contracts with doctors and clinics and hospitals and so forth. But again, there's not a lot of room for negotiation, and for the most part, all hospitals are paid about the same.
Okay. So there was an article in the newspaper this weekend regarding the need for new management at Kaweah Health. Can you address that article?
Yeah, I read the article. It was in one of the letters to the editor in the Sunday edition of the Visalia Times Delta. As I read the letter, it made no mention whatsoever to a change in management or management at all. It was actually the headline that the editor writes to catch your attention. So the author of the letter did not suggest there needed to be a change. It was an editorial comment by the paper, which I don't think it was quite appropriate. But nevertheless, I understand what the writer was saying. And once again, no criticism of the writer, but because this person is probably representative of most people across the country, and it's that they don't know what's going on in the healthcare industry. They're not following it. It's not on the local news until really my letter, I think, is the first time I've ever seen anything. It certainly surprised all the television stations, and all the media outlets that I've done interviews with had no idea, because you just don't see the news out there. Unless you're in healthcare like us and you're reading, the Healthcare Advisory Board and articles coming from the American Hospital Association. If you read Kaufman Hall, which Kaufman Hall is one of the nation's largest healthcare finance companies or consulting companies. They've been following the hospital industry throughout the entire pandemic. They've been publishing reports all the time, and I've been making reference to those reports as I meet with different community groups. I just picked up one of their headlines. So in this report that they released in September of 22, they wrote, ultimately, U.S. hospitals are likely to face billions of dollars in losses in 2022 under both optimistic and pessimistic models, which would result in the most difficult year for hospitals and health systems since the beginning of the pandemic. I made reference to the Providence Health System's $1.2 billion loss and Common Spirit's $1.3 billion loss. I think the woman that wrote that letter to the editor, she made reference to Adventist Health and St. Agnes and maybe Community Regional and how they're not suffering, any financial harm, and they're not writing letters to the governor. But that's not true. So go onto the website or go onto the internet, Google those hospitals. In 2020, St. Agnes laid off 175 employees. Adventist Health laid off 52 employees last month and more than 1,000 employees in 2021. Community Regional Medical Center laid off 658 employees in May of 2022. So, that might be kind of something that maybe we should have done it different. These hospitals, just like us, who early on in the pandemic were suffering major losses, they started laying off employees immediately. We didn't. We didn't lay off employees. We froze pay rates. We didn't make a contribution to our 401k plan, but we didn't lay employees off. And so we said we would fund our shortfalls through cash reserves. But now our cash reserves are depleted, and we're getting hit with that, kind of the 1-2 punch of the pandemic aftermath. And so it now is forcing us to lay off employees. But literally, I picked up this article today. 35 hospitals and health system across the country that in every state in the country are laying off hundreds to thousands of employees. So I think this reader, the author of the letter, is just not aware, not informed, and thinks that that all other hospitals are doing well because they're not speaking out. And so we spoke out, and I'm glad we did. But it, does kind of make us a target, so I understand that.
All right, so your NPR interview, is it still up? Can people still listen to it? Where's it at?
I don't know. I got to look to the three of you to find that. I haven't even heard it myself. I heard they broke it up in little snippets and.
We can find it and then add a link to,
Yeah,
send
we
it to Deborah.
Okay.
Okay, and I can send that out to our community engagement group, so we will take care of that. And Gary, it's 1 o'clock. So
Oh, perfect.
we finished right on time.
Stuck
so
the
thank you
landing,
for
as they
that.
say,
Yeah.
huh?
Yeah.
Yeah, so thank you again to all of you as we get ready to celebrate Thanksgiving with family and friends on Thursday. It's a time for us to just kind of pause, think about all the blessings in our lives, all the things that we're thankful for. And I'm thankful to be a part of this phenomenal organization. I'm thankful to work with people like Deborah and Kelsey and Maria and the 5,200 employees that we have. And I'm incredibly thankful to all of you. Our community members who have been supporting this now for 5 years. That's just remarkable. So just want to say thank you for tuning in. It was great to see many of you in person just a couple weeks ago. So I just want to wish you a very, very happy Thanksgiving. Stay healthy and don't feel bad about going off your diet on Thursday.
I've already started.
Should I talk about food, Maria? Is that you always want me to talk about food? So, yeah. All right. Have a great weekend or a great week.